All of the following drugs will potentiate the action of D-tibochlorine except the options given are Neomycin, Neostigmine, Polymyxin B, Clindamycin. The right answer for this question is option B, Neostigmine. Why? D-tibochlorine is a non-depolarizing skeletal muscle relaxant. Neostigmine, it's a choline esterase inhibitor going to accumulate acetylcholine. It is useful for reversal of action of non-depolarizing SMR. So question, for the reversal of non-depolarizing skeletal muscle action, what we using is neostigmine. We have one more drug called Cimetidine. It's a newer drug useful for reversal of action of prochronium and vecronium. Remember, in general, the drug useful for reversal of action of non-depolarizing SMR mean neostigmine. A newer drug useful for reversal of prochronium, vecronium mean think of Cimetidine. Whereas other options like neomycin, polymyxin B, clindamycin, these are some of the antibiotic going to potentiate the action of skeletal muscle relaxant. So what we should know is what are all the antibiotic going to aggravate the actions of skeletal muscle relaxant. Aminoglycoside, macrolide, quinolones, tetracycline, colistin, and lincomycin. These are some antibiotic going to aggravate skeletal muscle action. How these drugs are causing muscle relaxation? For example, look here. Imagine it's a cholinergic neuron and imagine it's a skeletal muscle. In the skeletal muscle, we have cholinergic receptor called nicotinic receptor called NM. Here N stands for nicotinic receptor and the M stands for skeletal muscle. So a cholinergic receptor that's seen in the skeletal muscle is NM receptor. And look at the neuron. In the neuron, there is one channel called calcium channel. Whenever the calcium channel get open, calcium entry occur. Once calcium enter, the calcium will pushes the vesicle. The vesicle containing neurotransmitter ACH, acetylcholine. So when calcium enter mean, the vesicle is pushed down and the ACH get released. The released acetylcholine going to act on NM receptor and causing skeletal muscle contraction. Whereas if I use aminoglycoside, an antibiotic, the aminoglycoside going to inhibit calcium channel activity, thereby preventing the release of ACH, inhibiting release of ACH, thereby causing skeletal muscle relaxation. So aminoglycoside and other antibiotics like tetracycline, polymyxin B, all these are causing skeletal muscle relaxation. For treating this case, we should give calcium supplementation along with neostigmine. Neostigmine, anticholinesterase, going to accumulate acetylcholine, useful for reversal of action of non-depolarizing SMR. That finishes first division. Now we move on to second question. Which one of the following drug has additionally calcium channel blocking property and antioxidant property? The option given are betaxolol, bivamtalol, carvedilol, celiprolol. Here one important question. Any beta blocker having extra property mean we call this third generation beta blocker. So question, any beta blocker having additional property mean they called as third generation beta blocker. First invented drugs are non-selectively blocking both beta 1 and beta 2. The non-selective beta blockers are called as first generation, whereas cardio-selective beta blockers, that is those beta blocker which are predominantly blocking beta 1 receptor, they called as cardio-selective beta blocker. They comes under second generation beta blocker, whereas any beta blocker having additional property mean they called as third generation beta blocker. Now the question is, which one of the beta blocker having additionally calcium channel blocking property as well as antioxidant property? The answer for the question is option number C, corvidilol. So we should know what are the properties of corvidilol. Remember, corvidilol, a beta blocker additionally having alpha blocking property, antioxidant property, anti-inflammatory property as well as calcium channel blocking property. It's a very important drug. It has additionally alpha blocking property, antioxidant property, anti-inflammatory action as well as calcium channel blocking property. It's FDA approved beta blocker for the treatment of congestive cardiac failure as well as hypertension. Remember, among the beta blocker, the best beta blocker for treatment of congestive cardiac failure means think of carvedilol. Now coming to other option, betaxolol. Betaxolol, a beta blocker having additionally having calcium channel blocking property. Then option B, biventalol. Biventalol, a beta blocker having additionally alpha blocking property. In this area, you must know one more important point. What are all the beta blocker having additionally alpha blocking property? This important MCQ. So you should know beta blocker having additionally alpha blocking properties are number 1, labetalol, number 2, carvedilol, number 3, bucindolol, and then biventalol, drug niprodilol. In this, the first two drug, labetalol, carvedilol are very famous beta blocker. And coming to option D, celiprolol. Celiprolol, a beta blocker having additionally nitric oxide releasing property. An extra important point, what are all the beta blocker having nitric oxide releasing property mean? We have nebivolol. Other than celiprolol, we have nebivolol, niprodilol, bobindolol and cortiolol. All these are beta blocker having additionally nitric oxide releasing property. In this MCQ, extra one point you should know, there is one drug called sotalol. Sotalol, a beta blocker having additionally potassium channel blocking property. Whereas we have one drug called tilisolol. Tilisolol. It is a beta blocker having potassium channel opening property. This is also important. Sotalol, a beta blocker having potassium blocking property, whereas tilisolol, a beta blocker having potassium opening property. This is also very important. Next MC question. Question number 3. All of the following antipsychotic drugs having partial D2 agonistic action except, question is on except. Option given are aripiprazole, cariprazine, brexpiprazole, paliperidone. Now, all of the following antipsychotic drug having partial D2 agonistic action except. First of all, look at the option. All the options are atypical antipsychotic. First of all, you should know Atypical antipsychotic mean those antipsychotic drug acting by blocking 5-HT2 receptor. So, all are 5-HT2 antagonist. Answer for the question is option number D, paliperidone. Why mean? Paliperidone actually a active metabolite of risperidone. Paliperidone is an active metabolite of risperidone, which is the 5-HT2 blocker, additionally having D2 blocking property. So remember, paliperidone having 5-HT2 blocking property plus D2 blocking. Because of blocking D2, it may cause side effect of EPS problem. So any drug blocking D2 mean they may cause risk of extra pyramidal side effect. And one more point actually, paliperidone is an active metabolite of risperidone. That's a one and only antipsychotic approved for schizoaffective disorder. And coming to other option, ABC. Look at this option. All these are atypical antipsychotic. That means 5-HT2 blocker. But they have additionally partial D2 agonism property. For example, okay, aripiprazole, a drug having 5-HT2 blocking property plus partial D2 agonism. And then three more newer drug. Lumateperone is a 5-HT2 blocker with a partial D1, D2 agonism. Cariprazine having additionally partial D2, D3 agonism property. Then brexpiprazole having partial D2 agonism property. So usually antipsychotic mean it should be a D2 blocker. But there are some atypical antipsychotic having additionally D2 agonism property. This is point very important. Next, question 4. Which one of the following adverse effect may occur more commonly with oxcarbazepine than with carbamazepine? Options are vestibular toxicity like vertigo, GI toxicity like nausea, vomiting, hematological toxicity like aplastic anemia, and hyponatremia. Answer for the question is option number D, hyponatremia. First of all, we should know carbamazepine, one of the important anti-epileptic drug. What are the important adverse effects of carbamazepine? Look at the common adverse effects of carbamazepine includes bone marrow suppression resulting in agranulocytosis, sometimes causing aplastic anemia. And one more important point, carbamazepine in a patient with HLA-B150 gene. In this genetic patient, it may have risk of causing Stevens-Johnson syndrome. So in a patient with HLA-B150 gene, in this genetic patient, for treating epilepsy, if you give carbamazepine, there's a high risk of causing Stevens-Johnson syndrome. And one more important point, carbamazepine having SIADH property, that is syndrome of inappropriate ADH secretion. Because of causing syndrome of inappropriate anti-diuretic hormone secretion, it causes too much of water retention. By causing too much of water retention, there is a risk of dilutional hyponatremia. So, an anti-epileptic agent causing hyponatremia means think of carbamazepine. Now I am going to compare oxcarbazepine with carbamazepine. Look here. There are two important derivatives of carbamazepine. One is called oxcarbazepine. One more thing called acylcarbazepine. These two drugs are derivative of carbamazepine. The advantage is these two drugs having less chance of causing myelosuppression, less chance of causing Stevens-Johnson syndrome. But these two drug causes more SAADH action. Because the more SAADH action comparing to carbamazepine, oxcarbazepine causing more chance of hyponatremia problem. So remember, oxcarbazepine on comparing to carbamazepine having high risk of causing hyponatremia. That finishes question number 4. Now question 5. All of the following drugs can be useful for treating cranial diabetes insipidus, etc. Options are chlorpropamide, carbamazepine, dimeclocycline, and desmopressin. Now look at the point action. All of the following drugs can be useful for treating cranial diabetes insipidus. Question etc. The answer for the question is option number C, demeclocycline. Remember, demeclocycline, a tetracycline causing side effect of diabetes insipidus. So, the drug itself causing diabetes insipidus. So, it is cannot be used for treatment of diabetes insipidus. Now, look at the option A and B. Chlorpropamide, a sulfonyl uric type of anti-diabetic drug. Carbamazepine, a sodium channel blocking anti-epileptic drug. These two drugs causing side effect of SAADH. So remember, chlorpropamide, anti-diabetic drug, and carbamazepine anti-epileptic drug, both of them causing side effect of SAADH. Because of causing SAADH, they can be useful for treatment of diabetes insipidus. Coming to last option, desmopressin. Desmopressin, a synthetic B2 analog of vasopressin. So, it's an analog of vasopressin mainly acting on B2 receptor. So, it's a drug of choice, very important. It's a drug of choice for treatment of cranial diabetes insipidus. So, remember, the drug of choice for treatment of cranial diabetes insipidus is desmopressin. Whereas for treatment of lithium-induced diabetes insipidus, we use ENaC, epithelial sodium channel blocker like amiloride. And for treating nephrogenic diabetes insipidus, we may give thiazide diuretic. So remember, I am repeating point action. For cranial diabetes insipidus, best option desmopressin. For treating lithium-induced diabetes insipidus, best option amiloride. And for treating nephrogenic diabetes insipidus, we may give thiazide diuretic. The finishes question number 5. Question number 6. Which one of the following angiotensin receptor blocker having thromboxane A2 receptor antagonistic action? Options are irbesartan, telmisartan, losartan, asilsartan. That means straight question. Among the ARB, which drug having thromboxane A2 receptor antagonistic action? The answer for the question is option number C, losartan. Now, what we are going to discuss is what are all the various examples for ARB and what are the important properties we are going to study. For example, angiotensin 2 going to act on angiotensin 2 receptor. There are some drugs going to block the actions of angiotensin 2 at the receptor level. They are called as ARBs. So, example for ARBs are we have losartan, valsartan, telmisartan, olmesartan, candesartan, asilsartan, and irbesartan. Now we are going to discuss the properties of various angiotensin receptor blocker. First, losartan. Losartan having uricose uric action. Very important point. Because of having uricose uric action is it is the ARB preferred for treating hypertension in a gouty arthritis patient. Point 2. Losartan having thromboxane A2 receptor blocking property. That means it has additionally anti-platelet activity. One more important point, losartan can be useful for treatment of portal hypertension. That's about losartan points. Coming to second drug, valsartan, a very important drug. Valsartan ARB given along with sacubitril. Sacubitril is a neprilysin inhibitor. So combination of valsartan plus sacubitril, one important combination useful for treatment of congestive cardiac failure. Now third drug, telmisartan, very interesting drug. The telmisartan is the ARB having PPAR gamma agonistic action. PPAR means peroxisome proliferated activated receptor gamma. PPAR involved in that PPAR gamma involved in glucose metabolism. So stimulation of PPAR gamma causes insulin sensitization, thereby controlling blood sugar. That means a ARB useful to control diabetes mean think of telmisartan. In other words, a anti-diabetic drug having PPAR gamma agonistic action is pioglitazone. So find out the ARB having pioglitazone like action mean the answer is telmisartan. Next important question. Among the ARB, look at this. The olmesartan and candesartans are prodrug. Remember, find out the ARB. Prodrug in nature mean olmesartan and candesartan. Remember, doctor, all ACE inhibitors of prodrug exception captopril, lisinopril. Whereas among the ARB, prodrugs are olmesartan and candesartan. And finally, irbesartan. Irbesartan ARB having one important property of controlling heart rate. So, irbesartan useful for treatment of hypertension with atrial fibrillation. That's the property based questions on ARB. Last one point. All the ARB similar to ACV are contraindicated in pregnancy, bilateral renal stenosis and in hyperkalemia. Extra one information, the olmesartan may cause side effect of sprue-like enteropathy resulting in GI toxicity. So find out the ARB causing sprue-like enteropathy mean think of olmesartan. That finishes some important special information regarding angiotensin receptor blockers. Question number 7. Regarding statin, find out the false statement. The option given are Lovastatin is a prodrug, rosuvastatin is a longer acting statin, pravastatin not metabolized by cytochrome P450 enzyme, atorvastatin unsafe in renal dysfunction. For this question, the right answer is option number D. Actually, among the statin, atorvastatin is safer statin for the patient with renal dysfunction. So, among the statin, the safest statin for patient with renal dysfunction is atorvastatin. So, option is option number D. Now, we go for discussion of some important properties of statin. We know statins are a group of drugs useful for lowering cholesterol, acting by inhibiting FMGE reductase enzyme. So, what are all the important MCQs on statin property based? For example, among the statin, lovastatin and simvastatin, these two statins are prodrug. All statins are active as such. So among the statin, prodrugs are lovastatin, simvastatin. Question number 2. Among the statin, pravastatin not undergo metabolism by cytochrome P450 family enzyme. That means among the statin, a drug having less chance of drug interaction is pravastatin because it is not undergoing metabolism by CYP family of enzyme. And we know one of the common adverse effects of statin is muscle pain, myalgia. Among the statin, a drug causing less chance of myalgia is pravastatin. And pravastatin also approved for treating hypercholesterolemia for children of 8 years and older age group. Next, very important question. Most of the statins are acting for 3 to 4 hours, whereas the two important longer acting statins are atorvastatin and rosuvastatin. Atorvastatin acting for about 14 to 16 hours and rosuvastatin acting for 19 to 20 hours. So these two drugs are longer acting statin. Very important question. Why important mean? The FMGE reductase enzyme involved in cholesterol synthesis. This enzyme is more active at night time, night 10 p.m. to early morning 1 a.m. In these 4 hours only, these enzymes are more active and more cholesterol synthesis taking place. Most of statin half-life is only 3 to 4 hours. So statin to inhibit this enzyme better given at night time. Whereas atorvastatin, rosuvastatin having longer half-life, so they can be used either in the afternoon or evening, even at bedtime. That's the advantage of atorvastatin, rosuvastatin. And one more important point, among the statin, atorvastatin is the choice of statin in a patient with renal dysfunction. It is safe in kidney failure. And the last one more important MC question. Among the statin, pitavastatin is the most potent statin. The most potent statin is pitavastatin. All are property based questions on HMG-CoA reductase enzyme inhibitors. It's a very important topic. Question number 8. Which of the following drug, if used chronically, is most likely to increase the toxicity of acetaminophen? The option given are cimetidine, ethanol, ketoconazole, and ritonavir. The answer for the question is option number B, ethanol. Now I will explain. Acetaminophen is also called paracetamol. It is a simple analgesic and antipyretic. This drug toxicity will be increased when taken by chronic alcoholic patient. Why? For this we should know first pharmacokinetic of acetaminophen. Look here. Acetaminophen, the so-called paracetamol, first undergo phase 1 reaction by CYP2E1 enzyme. Important question. A microsomal enzyme called CYP2E1. This enzyme involved in phase 1 reaction of paracetamol. By undergoing phase 1 reaction, paracetamol produces one metabolite called as N-acetyl benzoquinoiminoamine. This metabolite actually a hepatotoxic metabolite, but all of us are taking paracetamol for headache or for body pain. In our body also, this hepatotoxic metabolite get formed, but we don't develop liver damage with the paracetamol. Why? The reason is this toxic metabolite further undergo phase 2 reaction in the form of glutathione conjugation. By undergoing glutathione conjugation, the toxic metabolite get inactivated. Thereby, we don't develop liver damage with the paracetamol. But if the person taking overdose of paracetamol, that means in case of paracetamol poisoning, too much of this hepatotoxic metabolite get formed. we don't have that much amount of glutathione to make conjugation. So, in paracetamol poisoning, there is a risk of liver damage. And to prevent the liver damage, we should make availability of glutathione. So, we have some glutathione replacer called as N-acetylcysteine. This N-acetylcysteine is a glutathione generator. That is the drug of choice for treating paracetamol poisoning. So, find out the specific antidote for paracetamol mean think of N-acetylcysteine. We have one more drug called methionine. This drug also having glutathione repletion property. So this also used as an adjuvant along with the N-acetylcysteine for the treatment of paracetamol poisoning. It's about kinetic based question. The last question, drug interaction. Coming to the point, paracetamol produces a hepatotoxic metabolite with the help of CYP2E1. That means if I induce this enzyme, if I stimulate this enzyme, paracetamol rapidly going to form hepatotoxic metabolite. So we have one thing called ethanol. Chronic intake of ethanol will act as the inducer of CYP2E1. So, in a chronic alcoholic patient, if we give paracetamol, in that patient, paracetamol rapidly going to form hepatotoxic metabolite causing liver damage. So, chronic alcoholics are more prone for liver damage with the paracetamol because chronic intake of alcohol will act as a CYP2E1 enzyme inducer. That's why they are more prone for liver damage with the paracetamol. That finishes interaction between paracetamol and chronic intake of alcohol. Now, question number 9. Which one of the following drug is the CFTR activator useful in the treatment of irritable bowel syndrome? Options are linaclotide, lubiprostone, crofelemer, acimidolin. Now, CFTR activator, that is cystic fibrosis transmembrane regulator activator, useful for IBS, irritable bowel syndrome. Answer is linaclotide. Here the take message, look at, there are two important CFTR activator useful for IBS, includes linaclotide and plecanatide. Both are CFTR activator, thereby acting as a guanylate cyclase C agonist. They are going to increases chloride rich secretion, thereby increasing bowel motility. So useful for treatment of constipation type of irritable bowel syndrome. Now, option number B, lubiprostone. Lubiprostone actually a prostaglandin E1 analog. The action is, it's a type 2 chloride channel activator. Type 2 chloride channel activator, increasing intestinal fluid secretion, thereby promoting motility, useful for treatment of constipation dominant type of irritable bowel syndrome. Now coming to option number C, crofelemer. Actually, crofelemer is the CFTR inhibitor useful for treatment of HIV drug-induced diarrhea. Now option number D, acimidolin. Acimidolin actually a opioid useful for treatment of diarrheal dominant type of irritable bowel syndrome. It's a very important question. Important new drug useful for treatment of irritable syndrome. So important question. The next question. Which one of the following drug useful in gout having high risk of causing myocardial infarction and stroke? The option given are allopurinol, febuxostat, lesinurad, and rasburicase. So all the four option drugs are useful for treatment of gout. But question is, which is the drug useful for a gout having high risk of causing MI and stroke? The answer for the question is febuxostat. Febuxostat actually a xanthine oxidase enzyme inhibitor inhibiting uric acid synthesis. This drug having adverse effect of hepatotoxicity and also having high risk of causing MI and stroke. Now look at the option A. Allopurinol is another xanthine oxidase enzyme inhibitor, thereby inhibiting uric acid synthesis. The allopurinol most important side effect is causing hypersensitivity reaction, usually mild allergy, sometimes rarely causes Steven-Johnson syndrome and toxic epidermal necrolysis. Coming to option number C, lesinurad is a newer drug. It's a uricose uric drug. This drug common problem are may cause acute renal failure and also having risk of causing kidney stones, nephrolithiasis. And then rasburicase, a drug going to promote uric acid metabolism. This drug may cause adverse effect of GI toxicity like nausea, vomiting, and also diarrhea or constipation. Rarely, in a G6PD deficiency patient, this drug may cause risk of hemolytic problem. So we should know some important drug useful for gouty arthritis and the important toxicity. That finishes question number 10.